Alright, so we're going to just show some. Today we're talking about intersection syndrome again. And we're just talking about therapeutic devices, which would be like splints, stuff like that that the patient can use throughout the day. So actually initially I wouldn't immobilize this patient just because I think we could get better results with them moving and get good enough results with taping techniques and things like that that's not going to limit their motion so much. Immobilization can really have a lot of negative effects on the tendon health and obviously muscle atrophy and all that stuff, and I really don't want that. So we would avoid immobilization if we could. If the patient wasn't getting better after wasn't feeling better after the first 2 or 3 weeks of treatment, then we would probably think about doing like a thumb spica splint to immobilize, just because it's not really responding. Then I'd be thinking more be dealing with like a Decker-Veins syndrome than an intersection syndrome, but right now I think it's intersection syndrome. So there's some taping techniques that you can do that's sort of modeled after like a Mulligan technique to put the tissues in a more advantageous alignment so that they have better angles of pull. So again, we're focusing on that abductor pollicis longus and extensor pollicis brevis. So in our examination, we found that the patient does better with skin sliding to the radial side. So that's the way that we would want to do our taping. So basically all this is doing is it's just moving these muscles over a little bit and changing the angle that they're pulling, and hopefully it'll make the motions a little bit easier and less painful for you. So what you're going to do is you're going to find Lister's tubercle, which is right there, and then go like an inch or two proximal, which is about where those muscles intersect, and then you're going to put a pressure on there and then radially deviate, and then she'll flex and extend. So let's extend and then flex, and just move your wrist around, move that thumb around a little bit. What we're looking for is decreased pain, so we'll pretend like if she had pain that's decreasing her pain. So since that's decreasing your pain, I want to tape it to kind of keep it there. Okay, does that make sense?
Yeah.
All right. So what I'm going to do is take this piece of tape here, and I'm going to tack it down on her skin, just like that. And this is better with kinesio tape than just light tape, but I just have light tape. So you're going to hold that there. And then I'm going to take my finger and get in there and put a little pressure and radially slide the skin, and then she's going to tack that tape down and bring it around like so. And then we'll do probably 2 more strips of tape, just like that. So hold up, and I'll push down. She'll bring the tape down. Great. And pull it around. Awesome. 1 more strip. And grab the tape. Good. So that's going to affect the tendons of the thumb that are inflamed. The other thing that we found was good was radial deviation of the carpal bones, along with a slight superior rotation on the thumb side. So again, just have white tape, but this is a technique that I would do with stiffer tape like leukotape to actually get the tissues to stay where they are, because leukotape's a lot stiffer. But what we want to do is basically mimic that mulligan, or that mobilization with movement technique. So what I'm going to do is take some more tape, and I'm going to tack it down on the ulnar side, and we're going to tape there. And I'm going to radially deviate and superiorly rotate, and then she's going to bring that around, and then I'll grab it on the other side, and we'll go like that, and tack it down just like that. Again, this is more effective with leukotape than white tape. White tape is going to stretch out after a couple minutes of wearing it, so it's not going to do very much for you. This is just for demonstration purposes, so hold that again. And I'm going to radial deviate and rotate, bring it around, and I'll push just like that. Now again, the reason we're doing this is because with our comparable signs, we found that radial deviation along with superior rotation of the radius decreased the pain. So we want to get that into those bones into that same position, but obviously I can't be there all the time to assist that. So we want them to stay there so she can still do her activities of daily living and work at her job without pain and stuff. And this is just to close it down a little bit. That's not doing anything, not pulling anything. So this is something that I would implement pretty much right away. First, right after the examination, I know which motions and which slides make her feel better. So I would just implement this right away. And you can do your exercises with this taping on if it decreases the pain. You'd want to decrease your dependence on taping techniques as time goes on, so that by the end of treatment you're not needing to do it at all. But obviously in the first stages we want to be able to exercise and move without pain, so if this decreases the pain, we're going to do it. If this doesn't work, if you're not feeling, your patient's not feeling better, after 2 weeks of this and they're just not feeling any difference, maybe even a week of it, then you would possibly want to think about using a thumb spica splint. I don't have one of those, but check Google out for a picture of one. Alright, thanks.